Good afternoon. Thank you for joining us today. This is the California Telehealth Policy Coalition webinar on coding for COVID-19, how to bill for telehealth during COVID-19. My name is Kwong. I'm the Executive Director at the Center for Connected Health Policy. CCHP is the convener for the Telehealth Policy Coalition. Next slide, please. The Telehealth Policy Coalition is a coalition of over 70 statewide organizations interested in telehealth policy. We meet monthly. If you are interested in joining the coalition, please feel free to go to the website and send us an email letting us know that you would like to join. Next slide, please. We also do several fact sheets that we have available for the public for download. These are general informational fact sheets regarding an overview on telehealth and its role in the pandemic, FAQs that you can give to patients and consumers who may want more information on telehealth, and how to choose a telehealth solution. Again, all available on the coalition's website. Next slide, please. Purpose of today's webinar to answer some frequently asked questions regarding billing for telehealth during the COVID-19 state of emergency. We hope to help stakeholders identify which services and fees can be billed through modalities, which modalities, and by what provider, and distinguish billing routes for different payers. Next slide, please. Today we'll have an introduction to our agenda, the introduction to our guest speakers, and then we have a structured FAQ on some of the most frequently asked questions that we've encountered regarding telehealth billing, and then an opportunity for people to submit their questions. Please note that the chat function is not how you would submit questions. We ask that people submit their questions through the Q&A function. That way, if we run out of time, we will be able to download those questions and try to answer them after the webinar. Next slide, please. Our speakers today include Bao Xiong, Assistant Director of Healthcare Operations for the California Primary Care Association, and Carol Yarbrough, Business Operation Manager for Telehealth at the UC San Francisco. Next slide, please. We also want to make sure that we thank the sponsors for today's webinars. That includes the California Healthcare Foundation and the National Consortium of Telehealth Resource Centers. Next slide, please. So we'll begin with an overview of telehealth and telephone billing for FQHCs and RHCs, and I will now turn it over to Bao.
Good afternoon, everyone. May, can you hear me okay?
Yes, we can, Bao.
Okay, wonderful. So I'm going to start, as May mentioned, by providing a brief overview of telehealth and telephone billing for FQHCs and RHCs. And I will note for the group that the following 10 or so slides contain a lot more information than I am able to cover on the webinar today, but I wanted to include the information in the slide deck for reference. I'm actually going to focus on 4 slides that are centered on Medicare and Medi-Cal billing requirements for telehealth and telephone services, specific to FQHCs and RHCs. I will skip a few slides along the way, so my apologies for that. They're a little bit less relevant to our conversation today, but still, I think, helpful information for you to have on hand. With that said, let's dive right in. If I can go ahead and have you advance to the next slide. I'm going to quickly pause. I'm actually getting a comment saying that the sound is not great. It's cutting out. May, are you hearing that on your end as well?
I am not. You sound fine to me, Bao. I'm going to ask,
okay.
and Carol is nodding her head. So it may be a connection that a connection issue somebody's having.
Okay, got it. Sorry, if you can go back 1 slide. Great. So as health centers are rapidly transitioning to virtual care, it's important for them to be aware of what telehealth and telephone services are covered for the various payers. So for Medicare, FQHCs and RHCs can serve as telehealth originating site and also as distant site providers. When the FQHC or RHC is serving as the originating site, the FQHC or RHC can bill the originating site fee. And then when they are serving as the distant site, they can go ahead and bill for covered telehealth services at the fee-for-service rate of $92.03. On the Medi-Cal side, FQHCs and RHCs can serve as the originating or distant site provider. And can bill their PPS or their air rate for both synchronous and asynchronous telehealth services. And then I do want to note, you'll see in that box in that darker green there, that during the COVID-19 public health emergency, Medi-Cal is allowing FQHCs and RHCs to provide audio-only telephone services, which will be reimbursed at the PPS or air rate if the visit meets all of the documentation criteria, which we'll talk about in a little bit. Otherwise, it would be billed fee for service. Next slide, please. So outlined here are the requirements for Medicare synchronous telehealth services. A lot of information. I'm not going to go through all of this in detail, but I wanted to quickly note that during the COVID-19 public health emergency, CMS has relaxed certain requirements that allow for patients to more easily access telehealth services. And so this includes waiving the video requirement for certain counseling education services and for audio-only telephone evaluation and management services. Additionally, waiving the established patient requirement, which allows FQHCs and RHCs to provide telehealth services to both new and established patients. And then also waiving the originating site restrictions, which allows patients to access telehealth services from anywhere, including the patient's home, and additionally increasing the reimbursement rate for distance site telehealth services to $92.03. Next slide, please. So I do want to spend a little bit of time on this particular slide that has the billing guidance for Medicare distance site telehealth services. At the end of April, CMS released revised telehealth guidance for FQHCs and RHCs, which are outlined on the slide here. And I do want to note that the billing instructions are a little bit different for FQHCs and RHCs at this time. So let's go ahead and walk through what that billing looks like for RHCs first. For telehealth services that were provided between January 1, 2020 and January 30th of 2020, RHCs bill using the HCPCS code G2025 with the CG modifier. And these claims will actually be paid at the air rate and then automatically reprocessed beginning on July 1, 2020, once Medicare's claims processing system is updated. Health centers should expect a recoupment for overpayments because they're only entitled to the $92.03 and not the full air rate. And then beginning on July 1, 2020, RHCs would start billing using HCPCS code G2025. And by this time, Medicare's system should be updated and paying at the correct rate of $92.03. So for FQHCs, the process does look a little bit differently. For services that are provided between January 27th, 2020 and June 30th of this year, FQHCs would actually submit 3 HCPCS or CPT codes, one being the FQHC PPS payment code, 2, the HCPCS or CPT code that describes the services furnished via telehealth, along with the modifier 95. And then that third code is the HCPCS G2025 with the 95 modifier. And then similar to the billing process for RHCs beginning on July 1 of 2020, FQHCs would start billing with just the one HCPCS code, G2025, and the 95 modifier is optional. Next slide, please. So what I have on this particular slide here is a scenario in which the FQHC or RHC is serving as the originating site. I'm not going to walk through the scenario in detail, but I do want to note that FQHCs and RHCs are authorized to serve as originating site providers without regard to their geographic location during the public health emergency. And then additionally, the patient and the provider can be located anywhere during the telehealth visit, including their respective homes. Next slide, please. What's on this slide are a couple of billing examples for Medicare telehealth distance site services. I'm not going to walk through this in detail, but just wanted to put this in the slide deck for reference in case you're wondering what the actual billing codes would look like on a claim form. Next slide, please. We're going to take about 20 seconds or so to answer this poll question before we transition to Medi-Cal telehealth billing. Will we be able to see the responses?
I believe once the polling is ended, the responses should come up.
Okay, great. And can you just let me know when it's available?
Sure, I'm about to end it right now.
Wonderful, thank you. All right, great. So the question is, RHC's bill for Medicare telehealth distance site services provided on January 27, 2020 through June 30th, 2020, using A, HCPCS code G2025 with CG modifier, B, HCPCS code G2025 without the modifier, or HCPCS codes corresponding to the services being provided. And the answer is A. The majority of you did answer with that A option, so great job there, and thank you for participating. I will go on to the next slide, please. Once again, very heavy text slide here, my apologies. Again, I'm not going to walk through the individual requirements. You'll see here there's information about modality, eligible provider, eligible services, and such for Medi-Cal telehealth services for both synchronous and asynchronous telehealth. Of note, during the COVID-19 pandemic, DHCS is temporarily waiving the established patient requirement, the 4 walls requirement, and also the face-to-face requirement, which now mean that FQHCs and RHCs can provide telehealth services to both new and established patients outside of the 4 walls without that face-to-face requirement in order to bill their PPS or error rate. Please feel free to take a look at the slide on your own time. Hopefully you'll find that information helpful. Next slide, please. And then in terms of billing, the Medi-Cal billing requirements are the same for both synchronous and asynchronous telehealth services. FQHCs and RHCs bill using the exact same process as they would for other billable visits where the patient is in person. And this means using the appropriate all-inclusive billing code sets and the related claims requirements. I've included here a couple of examples. It's not an exhaustive list. Again, just a couple of examples to give you a sense of what this would look like on your claim form. So that first example there for a medical visit with a Medi-Cal fee-for-service patient, you would bill using the revenue code 0521 with the HCPCS code T1015, and those would go on the payable line. And then in addition, you would include your CPT codes that correspond to the services that were provided during the visit as informational line items. And just a reminder, the informational line items are not separately billable. And then for your teledentistry visit, that last example there where it says dental fee for service, those visits would be billed with your local code 03. And then a really quick note that FQHCs and RHCs do not bill Medi-Cal with the place of service code 02 or the 95 modifier. Next slide, please. Again, here is a telehealth billing scenario for Medi-Cal in which the patient is located at home. FQHCs and RHCs serving as the distance site are able to bill for these services at the PPS or error rate. Next slide, please. And then similar here, a very similar scenario. If you take a closer look at these 2 slides, you'll notice that the first one is for a Medi-Cal fee-for-service patient. And then the second example here is for a patient that is enrolled in a Medi-Cal managed care plan. And so you would bill the managed care plan and then turn around and bill your wrap to Medi-Cal. Next slide, please. A couple of billing examples here, what it would look like on a claim form. I'm not going to walk through these examples, but you'll see in that top example, it is it's a claim for an RHC telehealth visit with a patient that's enrolled in a Medi-Cal fee-for-service plan. And then that second example there is for a patient that's enrolled in Medi-Cal managed care. Next slide, please. So I do really want to emphasize that during COVID-19 or the COVID-19 public health emergency, DHCS is allowing FQHCs and RHCs to provide and bill for audio-only telephone visits. But in order to bill at the PPS or the air rate, the visit has to meet specific documentation criteria, which is outlined here. So one, the provider has to document the circumstances involved that prevent the patient or the visit, from being conducted face-to-face. And you can, that could mean that the patient is quarantined at home or that the patient is following local or state guidelines directing that the patient remain at home, or the patient lives remotely and doesn't have access to internet. And then secondly, the provider has to be able to document that the telephone visit is intended to take the place of a face-to-face visit, and that goes in the medical record. Thirdly, the provider has to document that the service is medically necessary and clinically appropriate to be delivered via telephonic communication. And then fourth, the provider needs to be able to meet all of the other procedure and technical components similar to an in-person visit. And this would include components like the patient history, description of provider services, assessment, examination notes, diagnosis, treatments, etc. And then lastly, the provider needs to ensure sufficient documentation in the medical records that satisfy the requirements of the specific CPT or HCPCS code that you're billing for. In the instance that the visit does not meet all of the documentation criteria that I just went over, the telephone visit can still be billed to Medi-Cal, but it will be billed at the fee-for-service rate of $13.69 and not at the FQHC or RHC's PPS or air rate. Next slide, please. So what's outlined on this slide is the billing requirements for telephone visits for Medi-Cal when it meets the documentation criteria and then when it does not. So in that first column there, you'll see this is the billing guidance for a Medi-Cal fee-for-service patient that's receiving care through a telephone visit. So in this instance, you would bill using the applicable revenue code that corresponds to the type of service being provided and the HCPCS code T1015 in the payable claim line. And then you'll also include the appropriate CPT code. DHCS is instructing health centers to use the codes for new patient or established patient. And this is supposed to help them track which claims were done through telephone. That's our understanding as to like why they're requesting that health centers use those particular CPT codes. And then similar for the managed care patients, in that second column there, the same instructions. And so I won't go over that again. Just noting that you're going to be billing for your wrap. And so you'll include your modifier SE in the payable claim line. And then as I just mentioned, for your telephone visits that don't satisfy the documentation criteria, and that third column there, you would bill with HCPCS code G0071 in the payable line, and you would not include any corresponding CPT codes. Our understanding in conversations with DHCS is that they have a mechanism in place that allows for the claims processing system to separately process those claims. So your G0071 would be processed separately from your PPS claim. Next slide, please. I think I have one more poll question, Robbie, but I'm not quite sure if that actually made it into the presentation. So it doesn't look like it. So I will go ahead and stop there. I'm not quite sure, May, if you want me to take questions at this point, or if you want us to just transition into the next portion of the presentation.
I think we're going to go over to Carol next for some brief comments, but before we do that, a couple of housekeeping things. If you have questions for our presenters, please put it in the Q&A. Do not put it in the chat. The reason we ask you to do that is because if we don't get to your questions before the end of the webinar, we're able to download the Q&A. We cannot download the information in the chat. So we want to make sure we don't miss anybody's questions. Please put your questions into the Q&A function. Do not put it in the chat. Several people mentioned that they were having audio trouble. There are some phone numbers that you can dial into if you are still having audio trouble. Those numbers are in the chat, and I will repaste them again so you can find them. And for those who have questions on whether the PowerPoint or a recording of the webinar will be made available, yes, it will. It will be posted on the Coalition webpage after the webinar, usually within 24 hours. So please make sure to check that if you're interested in downloading a copy of the PowerPoint. Now I'll turn it over to Carol Yarbrough for a few comments before we get into some more specific questions that we have received. Carol?
Yeah, good afternoon, everyone. Thanks for taking time out of your busy days to join us. I didn't prepare any specific slides as I tend to wax prosaic in terms of answering your questions, and really just wanted to get to the nitty-gritty. I think a great one to take out of the chat and kind of transfer into this Q&A following up on what Bao just set out so wonderfully, as I'm very unfamiliar with FOHC billing requirements, is Ingrid Hercules just asked, are technical components requirements for E&M services reduced to time? And complexity of medical decision making. There is a slide on that a little bit later when we talk about Medicare. So we can just dig right into the Medi-Cal. I think a lot of the things that you're asking we'll probably get to in our Q&A. So next slide. So how do I bill for telephone visits? This has been kind of a crazy thing. What we had is no ability to bill for any type of telephone calls prior to the PHE, the public health emergency. There was one code for CCS patients where a nurse practitioner could actually bill for time if it was in reference to a CCS patient. That was the only billable phone encounter I'd ever seen in all my days. But now, you know, and then of course the G2012 came out for the virtual check-in, and we thought, well, that's great, it's paying for a telephone call. Well, it really was just for a virtual check-in. Like, how you doing? Do you need to come in? Do you not? It really didn't require any kind of medical necessity around there. It was just, you know, how are you doing? Do you need to come in? So the use cases we were provided with over the last month and a half, we accumulated these questions. So physician has a phone visit following surgery with a Medi-Cal managed care beneficiary. Following surgery, oh, how closely did I read this? Okay, so if it were over the 0-day global, of course, you can bill for that phone visit since you're meeting all the E&M codes requirements except for the in-person component. And you know, you're going to bill it out using the same E&M codes that you would generally use. If it turns out it was just a check-in after the surgery, and didn't meet the components of the E&M, that's when you'd bill a virtual check-in. Now, say the component was maybe 10 days after the surgery and it fell into a global. I think that would be a 99024 with a modifier 95 and an 02 because it's falling within a global period after a surgery, and certainly the 90 days global period for surgeries. And please understand that the consult codes we refer to in the use case as well, and the outcome is the consult codes that are still allowed by Medi-Cal that really are not payable by CMS anymore, and to a certain extent, many commercial payers. Next slide. Okay, so this is how do I bill for telephone visits if I'm in FQHC? I'm gonna send that one back over to Bao.
All right.
She's a pro.
Happy to take this one. So we just talked about billing for telephone visits just a couple of minutes ago. In this particular instance, an FQHC providing telephone visits, you would bill either your PPS or your air rate, again, if that visit meets all of the documentation criteria that I went over just a little bit earlier, and it's also listed on this slide here. If it is eligible for the PPS or the air rate, you would bill using the same process as your in-person visit. But again, if it doesn't meet all of the criteria, you would bill fee for service using the HCPCS code G0071. And it's a minimal reimbursement rate, but do keep in mind that this particular service is intended for patient triaging. So while the reimbursement rate is a little bit low, it does allow for health centers to receive some kind of reimbursement for triaging.
And it really does provide some kind of indicator to the payer that you've provided some kind of follow-up treatment or treatment at all. So it's nice, you know, it's kind of a code of like, hey, we talked to that patient and this is their diagnosis code. All right, next slide. What's the difference between a telephone E&M and a virtual check-in? We briefly alluded to that earlier. It is in the service provided. Patient not sure if she needs to schedule a visit, sends her provider a message with an update in her symptoms through the patient portal. Now, virtual check-in can be either via synchronous face-to-face, it can be through digital messaging, or it can be by telephone, as long as you document the encounter. So this one indicates that the patient was sent their provider a message through a portal, and yeah, the provider responds, I don't think you need to come in, but thanks for checking in. I'm gonna bill you a G2012. Now, we use place of service 11 because this is a virtual check-in and it's virtual care. It's not telehealth. Now, this is a great way to know the difference between what CMS considers telehealth versus virtual care. Anything that seems to say virtual or digital kind of gets away from the fact that they really don't want to put in that place of service geographic exclusion that existed prior to PHE. So, you know, moving forward, you can still bill with a G2012, so that's kind of nice. Example number 2, schedules a telephone visit. Yeah, so they're going to use an E&M telephone code, and that would be your CPT codes, which we've listed in a further slide as well as the 99441, 42, or 43. Next slide. Can I bill for an encounter if the patient is located at home? I think we can all respond a resounding yes on that one after the last 2 months. Providers at home, billers are at home, May's at home, Ray's at home. We're all at home and we're doing work just as well as if we'd been in a business setting or a clinic setting. Yes, so you can bill for the visit. In terms of the FQHC, Bao.
Yeah, so the same is true for FQHCs and RHCs. The patient can be located at home. The provider can be located at home during the telehealth visit, and it is billable.
Great. Next slide. All right, how do I bill for originating site and transmission fees? Boy, we love this one too. Now, it depends. So say your patient comes into the clinic. Now, I know this is for Medi-Cal. So you would bill your normal E&M, and then it would be split out and would get a facility fee in addition to your professional pro fee associated with that visit. But for a telehealth visit, what was occurring is that patients usually going into a facility that that's designated. They're there at their primary care physician's place. They're at a hospital walk-in clinic. They need to see a specialist. That facility can bill an originating site fee, pays around $28, $27, I want to say, or is it 37, 36, 27. So for live video, yeah, we can bill that originating site fee if the patient is at a facility. If the patient's at home, for Medi-Cal, cannot. So, right, so a contracted physician provides live video services from a facility-based clinic to a patient at home. The facility-based clinic can bill a transmission fee, which pays about 27 cents a minute, which is awesome. And you can typically do that either by crosswalking your E&M code, which if you're billing by time, 99213 would be 15 minutes. You get 15 units of T1014. You can do the math on that and see how much you're going to make. DHCS does not reimburse for any telephonic services for originating site or transmission fees for FQs in other locations. Example 2. Live video service from the patient's home to a patient, from the physician's home to a patient located at home. Yeah, cannot bill the originating site fee. It's pity. Now, we'll get to Medicare later. You can bill an originating site fee for Medicare. Next slide. Can the transmission code be billed by the hospital, treated like an in-person quality assurance fee program? Now, this was a question we had encountered, so did a little research. So the contracted physicians at a facility-based clinic, there was live video to a patient at home for 25 minutes. Sorry for that typo. The facility-based clinic can bill a transmission fee of 25 units and to report these out under the hospital quality assurance fee program. The thing is, you should do anything that you normally would do for your quality assurance program, and then go ahead and tack on the telehealth things that'll help you make it through in terms of how you would normally bill a telehealth visit. Next slide. Telehealth services provided by ancillary staff. Resident provides derm services via telehealth. So, telehealth is another modality for care delivery. Ancillary staff. So these are people that do not have an NPI. They're not considered qualified health providers or QHPs by Medicare. Now, CCS GHPP has other providers listed as eligible providers. There's a nice link to the telehealth provider manual. And then certainly for residents, interns, they can see patients via telehealth. There's nothing preventing them from doing it. The hospital should bill for the resident's dermatology visit on the CMS 1500, as long as you've got an attendings attestation that they participated in the telehealth visit as they normally would if the patient had come in. Now, if the resident is moonlighting during the PHE at their own facility in order to provide emergency coverage, then they can bill out on the 1500 by themselves. Normally, it's not allowed. You can moonlight anywhere else by where you're getting your education. But during the interim final rule right now, you can moonlight at your own training facility. Next slide. Do I get paid for a well child visit? This comes up all the time. DHCS certainly is allowing to conduct well child visits. We want to keep the children well, keep them, you know, in their homes. The thing is that well child visits also often require vaccinations and other things along with the milestones that are being associated with that annual or the well child visit. So pediatrician at a private practice conducts a well child visit, provided at a subsequent in-person visit. The provider bills for one encounter, even though 2 visits occurred. So how about if that pediatrician was at a facility-based location? The provider would bill the telehealth visit on the 1500, the facility would bill the GO 463 for Medicare. For DHCS, it would be 1 visit. Bao, can you take the FQHC response for any other tidbits?
Yeah, absolutely.
Great.
So for the FQHCs and RHCs, we are able to provide well child visits and receive PPS or the air rate. If it meets all of the documentation criteria. And as Carol noted, the same is true for FQHCs and RHCs if it happens to result in 2 visits. So for example, if the visit initially starts out as either a telephone or telehealth visit and you're able to do certain components virtually, and then, you know, a couple of days later or even within the same day, you bring the patient in for, let's say, vaccinations, you would not be able to bill 2 separate visits. All of that will be considered 1 visit because the services that were provided in the second visit really are a continuation of that first visit.
Okay, next slide. Medicare, my favorite.
Okay, actually, before we get started on the Medicare questions, because we still also have Medicare and commercial payers, let's take a few questions in the questions box. First one is, when Medi-Cal be reported on the Medi-Cal claim? And Carol, if you're looking for the question, it's near the beginning.
It was that look, that consternation. What was the question again?
When Medi-Cal is secondary to Medicare, should G2025 be reported on the Medi-Cal claim? Because they're asking 2025. This might be for Bao, actually.
Yeah. Yeah.
Can you repeat the question, May? I can't see it in the chat box for some reason.
Yeah, it's near the top. So when Medi-Cal is secondary to Medicare, should G2025 be reported on the Medi-Cal claim?
Yeah, great question. I don't have an answer. Medi-Cal hasn't released guidance on how to bill for the Medi claims for your dual eligible patients, because when we talked to them, I think probably about a week ago, they had not actually seen the CMS guidance with the new code. And we did let them know that, you know, we are aware that most secondary payers don't recognize that new code. So it may result in some challenges with getting payment from the secondary payers. DHCS has agreed to do a little bit of research on that end and then get back to us with billing instructions. And as soon as we have that information, I would be happy to share that with the group.
Okay, thank you. And this other one is also probably for you, Bao. It's when billing Medi-Cal G0071 fee for service for FQs and RHCs, does that go on a UB claim form or a 1500 claim form?
My understanding is that it goes on your regular UB.
Okay. Okay, great. And then there was one here that I believe it was for Carol. It's looking for it right here.
I can answer this one real quick.
Yeah.
Can a provider provide telehealth in the ED? Any billing for the facility? Depending on your payer, it's a blanket yes for all of that. CMS released a new listing of codes that included all the 99281 through 85 CPT codes, in addition to the G0 codes that would indicate the services are being provided in an ED. The billing for the facility, if the patient is at the ED and you've got a distance site provider, yes, you should bill for the facility codes, as those are often separately leveled by coders. So the facility level of service for an ED can be different than the level of service done by a provider. So definitely should bill out the facility fee on that.
Okay. And Carol, here's another question for you. For audiovisual telehealth visits, what hospital-based clinic code should we use? Should we be using T1015 in addition to the T1014?
Okay, so the T1015 is, I believe, all-inclusive. That is HCPCS code for state medical agencies, clinic visit encounter, all-inclusive. You would not bill a T101, well, you would bill the T1014 for your minutes, and then the T1015 for the all-inclusive clinic visit. Does that make sense? We'll do more research on that. We'll get back to you on that.
Okay. And then there are quite a few Medicare questions, which we're getting now to the Medicare FAQ. So we'll just go on with that.
Okay. So I'm going to do my first poll visit, or my polling question on that one. Maybe Ray can get that up.
Yeah, it just launched.
Thank you. These are my top 3 at our facility. So I was just wondering if it was the same or different, or I guess you can't click all 3 at once. I want to know where your pain points are, listeners, viewers.
All right, I'll give it another 10 more seconds and I'll close it out.
Okay. Telephone E&Ms. All right, I'm going to answer your questions. You won't be in the dark no more. These will be your answers for your providers to learn and know. Okay, do I get paid for Medicare for a telephone visit? Yes, you do. As of March 30th, that fateful afternoon, when we all got the update to the Medicare interim final rule about telehealth, they had indicated that telephone calls were going to be added. Those are the 99441 through 43. They had been assigned work RVU since 2008. They had never been switched on as a active code for Medicare. So it was nice that it was there and ready to go. Then as of April 30th, they added a bunch of other codes that were telephone only or audio only if that's what the patient had. So, you know, during the PHE, now these are only for during the PHE. You could use the G2012 for the virtual check-in prior to this, but during this time period, for example, the 90853 in example number 1, that's usually only audio visual for telehealth. Right now, we can bill for this service as if it were audio visual. They're asking that we bill it out normally, so it'd be a 90853 place of service 95 or modifier 95 with your usual originating site place of service. Example 2, a patient initiates a virtual check-in. This is an odd one, right? So I'm calling or something. I just want to check out what's going on with me. And then it turns into a 5-minute online digital evaluation of the symptoms. So the provider could bill the G2012, or they could flip it over to the online visit as a 99421 through 3. And these are all time-based codes. You record what the complaint was and what the medical decision making was. These are time-based and MDM based. So you really don't need to have any kind of E&M things that you would, like similar to Medi-Cal, where they want you to put in as much as an E&M in there as possible to be able to bill out as a telephone or whatever. For this, they definitely just want what the problem was and how you resolved it. Next slide. What does a digital E&M look like? Hey, thanks for your message. We're offering e-visits. Thanks, I'd like to proceed. Next slide. Whoa, you sent me a picture. That looks really painful. Here, I've ordered you a new prescription, and after a couple of days, check back in with me. I spent a total of 25 minutes. Thanks. I'll follow your instructions. So this would get billed out as a 99242, because the 243 would be 31 minutes or more. So that's it. That's it. It's not text messaging, unless you can figure out a way to get that into your EMR. Say if it's text messaging through an app that connects with your EMR, that'd be great. That's totally billable. You need to set that up with your billing folks and make sure that you've got the ability to do so. All right, next slide. Told you I talked a lot. So what's required to document that telephone? There you go. Next slide. Okay, so in that interim final rule as well, CMS indicated that the 2021 E&M guidelines could be in use under the PHE. This is to save providers time, deliberation of how many physical exam elements do I need to document to get to the highest level of service, which we've had many animated discussions about in my facility. But you could just use MDM or time for the AMA 2021 E&M guidelines. And there's been some slight modifications to the table of risk. You can check it out. There's the URL for it. One thing that they did update, now this was implemented March 30th. What was changed on April 30th was that there are time parameters indicated around the minutes for the AMA 2021. So 15 to 29 minutes. Now you're just going to use the usual old time. Someone's drilling in my house. That's great. So the current associated minutes. You just don't need an HPI. You don't need a PE. It's just whatever time you have, and or if the complexity is such that you could bill at the higher level. Next slide. What providers? This is often, this took up a lot of time at my facility as well, and thank goodness CMS ended that discussion by saying that PTs, OTs, and SLPs are now eligible providers during the PHE. Occupational therapist employed by a non-FQHC or HC ambulatory facility, meaning there's a direct contractual relationship between this, let's see, OT can bill. There's not a contractual relationship between a provider and the OT. So the OT bills out as they normally would, 97167 via live video. Put a modifier 95 on the CPT code on the UB04 and send it in usual places of service for the clinic visit. I think that's Rev code 250. Example 2, physician employed by an FQ. Oh, that's for BOW.
I can take that one.
Yay.
I am seeing in the chat box, there are several questions around how to bill Medicare for a telephone and audio only telephone E&M visit. So this question sort of gets at that. So in this second example, it's a physician that's employed by an FQHC who conducts a routine office visit with an established patient. And the date of service is May 12, 2020. So in this instance, because the date of service is between January 1 of 2020 and June 30th, the FQHC would need to submit 3 CPT or HCPCS code. And as I mentioned earlier, those are 1, the PPS payment code, 2, the HCPCS code that describes the service, and you would need to attach a 95 modifier. And then 3, your G2025 with the 95 modifier. Now, if that service had happened, let's say July 2nd of 2020, the FQHC would instead just bill 1 code, and that's your G2025.
So there was someone asked in the chat, can I start billing the G2025 now? So I guess this answers our question. No, let's wait. Right? We're going to pen the claims.
Well, for RHCs, you can go ahead and actually start submitting them.
Okay.
Or need to submit the 3 codes. And then my understanding in reading the CMS guidance is that the telephone or the audio only telephone visits for FQHC until July 1, and then billed with the G2025 code.
Okay, cool. All right, next slide. How do I bill for Incident 2 services? So let's discuss what Incident 2 is. I am a therapist, I'm a respiratory therapist, or I'm an occupational therapist. I have a direct contractual relationship with the physician in a physician-based office who hired me. That is when you can bill Incident 2. And I know they've relaxed a lot of the Incident 2 requirements to allow for general supervision instead of direct supervision, which is great. As long as you've got a documented care plan, you don't need a physician in the next room saying, if you bend that arm too wide, I don't know what they would say for direct supervision. But generally means within calling distance or, telephone call. So supervising physicians can amend their care plans with these non-physicians to include telehealth. Now, for an occupational therapist who is working for an ambulatory facility setting, that would be billed out on the UB04 with a modifier 95 as we indicated earlier. So just understand what an incident 2 is. I know it's a hard concept, but it just means who hired that person. Did the medical center hire the person, or did the physician group hire the person? And whoever hired that person and pays their salary gets to bill for their services. That's it. Next slide. Can they bill for advanced care planning? Yes, via telehealth and telephone. That was added to that list of CPT codes that CMS brought out on the 30th. Next question. Commercial, I know, I told you I talked a lot. Okay, let's go on to the next. Oh, I had another poll. Last poll. It'll be quick.
While the poll is you're voting on the poll, again, I ask that folks, if you have a question, please put it in the Q&A box and not the chat box. That is so we can download it if we do not get to your questions during the webinar and answer it afterwards. So if you have a question, please put it in the Q&A box and not the chat box. That is so we can download it afterwards in case we do not get to it during the webinar.
All right, I'll be closing the poll in about 10 more seconds.
Here's a good question. What is the Medi-Cal place of service requirement for telehealth? There's information that states both. It depends. If you want to bill with the patient at a facility, then you would use O2 because you're filling the, it's a telehealth appointment. It fills all the requirements. 11 is going to be when they don't have audio visual, and you're going to put a 95 on it to make sure that it indicates that you're still going to get that E&M valuation. And I believe that's for managed Medi-Cal as well. All right, what was the highest snack? I wasn't looking at the poll.
Fruit salad.
Yeah.
Fruit salad. Oh my God. You guys are so good. I've gained 5 pounds eating peanut M&Ms. Okay. How do I build commercial telehealth plans for what is so great about this time period and not so great is this is the first time I've ever seen a published telehealth policy on any commercial payer website. As anyone else has, if you've tried to look for any kind of reimbursement policies or directions or direct, clear, concise information on how to bill for a claim for telehealth, it was non-existent up until about 4 weeks ago. So really, how do you bill? Go to the websites, figure out who your largest payers are, and go to the website. There's tons of information out there. Make yourself a grid, and it's going to tell you exactly how to bill, what place of service, what modifier, what type of E&M code, or what type of CPT code. All right, so use case, physician contracted with DMHC license plan, routine office visit, 99203, using live video. Yes, bill for it. CDI regulated insurer. So this is someone who has an employer-based insurance. I want to say Google or Facebook. These are plans that have their own insurance that are administered by Aetna or Anthem or whomever, Cigna, one of the big ones. And so if an employer is covering what is going to be paid for in that plan, they get to say what's covered or not. I think in either instance, if it's not paid, if you went to that employer and said, wow, you're not paying for telehealth, they'll say, well, that's really not good. I'm going to pay for it, especially during this time we're under right now. So go ahead and make the phone calls and go to the sites. Next slide. What rate? They have to pay us as they would pay for an in-person service. So here we have the store and forward here. In the first example, patient skin rash, that's store and forward, so that's a GQ modifier. Same scenario, except the payer is a CDI regulated insurer. Well, check the insurer's billing policy. Not required to pay for telehealth. So again, make that phone call, make the grid, and figure out who's going to pay and who you need to make a phone call to. Next slide. How do I bill them? Just go ahead and bill them. Next slide. All right, and here are some key considerations for May to go over. I really appreciate everyone's attention and participating this afternoon. And there are a lot of Q&A that I'm going to promise to answer with May and Bao. So, May.
So yes, thank you, Carol, and thank you, Bao, for some great presentations and answering some of the more common questions we have. We do suggest that folks also check with CMS, DHCS, CMHC, or other agency guidelines, especially from another state. Check with your department that handles Medicaid. They are issuing a lot of guidances. Policies are changing fairly rapidly, though we've kind of hit a, I think, more steady time period right now. But there have been rapid policy changes, so it's always good to double check with the agency in charge. As Carol was talking about, you got to reference payer policies, private payer policies, because they may have their own specific rules and requirements in how they treat telehealth. Review your CPT and HCPCS code descriptors carefully to make sure what you are billing for really qualifies underneath that particular billing code. Understand which of your providers will be providing telehealth, because even though CMS and for Medicare opened up the providers that they're allowing to cover telehealth, that may not be true of your Medicaid program. In California, Medi-Cal was pretty expansive, but if you are calling in from another state, then you may not have that same type of broadness within your Medicaid policies as well. And also private payers may have some limitations too. Document all visits and patient medical records. They relaxed some of those requirements underneath HIPAA. Some states have relaxed some of the information protection requirements as well, but you're still required to document information in the medical records. If in doubt, submit the claim. The worst that they can do is just say no and not pay you. But then again, if you had some doubt, they may actually pay you. So just go ahead and do that. And might also give you like a little bit of an idea if they do reject the claim, why they rejected it. And then you knew like maybe you needed to add a modifier, or it could be a simple fix for you. We are 1 minute over. I want to check in with Bao and Carol. Can you guys stick on for maybe another 5 minutes? Because there are some questions in the QA. We will not get to all of them, but we will download them. That's why I wanted people to put it into the Q&A box so we can download them and try to answer them afterwards. But we'll try to get to make maybe 1 or 2 questions now. Carol's nodding. Okay, great. So let's go through some of the questions. I'm just going to go in the middle here. Do global periods apply to FQHCs?
I'm not sure. I can research that. Is it showing up with like the individual who asked the question? I'm happy to get back to them offline.
Yeah, some people it is. Some people have typed in anonymously though. So that should also be downloaded when we download these Q&As. I believe it does identify who it is.
Okay.
So usually the global period will only affects the person that conducted the actual surgery. So, you know, I'm a surgeon. You come to see me in the clinic the week after, so I make sure that your wound is healing properly. That falls within the global surgery, the global period after surgery. If you go to an FQ for follow-up care after you were dismissed from, after you were let go from a like an orthopedic surgeon's care, and you go to the FQ for wound follow-up, that does not fall within the global surgery period, and you will get paid for that wound care. It's just that the surgery kind of bundles in all of that care for that particular physician group or person who did the surgery.
So this one I think I can answer. Do we anticipate DHCS will follow CMS and eventually allow the hospital-based clinics to bill as the originating site Q3014 when the patient is at home? Latest I heard is no, they were not going to do that at this time. So at this time, that's always at this time. Who knows? A couple of weeks, things could change. Things have been moving like that sometimes. But
tonight,
at this time, yeah. Carol?
It could change tonight.
Yeah. So, but at this time, as far as we know, no, they weren't going to do that. For EMM codes with 95 modifier for phone visits, do we use place of service 02?
For Medicare, no. For Medicare, you'll put the 95 and then the regular place of service that you normally would have conducted business in. For Medi-Cal, yes, 02.
And then I will quickly note that for FQHCs and RHCs on the Medi-Cal side, you would not use the place of service code 02.
Patient is in ED on site. ED physician also in ED, but he wants to do telehealth instead of seeing the patient face to face. Can you bill this visit both pro fee and facility for both Medi-Cal and CMS?
We've received guidance from Medicare in that last rule that, and in the FAQs, that if you're on site and using technology to see the patient to either protect yourself or to conserve PPE, that is not considered a telehealth visit. That is an on-site ED visit. So you would bill whatever documentation that you can that would fulfill any of those ED CPT codes. you have to be within 250 yards of the facility. For Medi-Cal, I am not sure.
Medi-Cal claim for RHC usually bill all-inclusive charges under PPS T1015. Are we allowed to bill for the T1014?
Oh, so that is that question. So
For an RHC though.
Yeah, so for the RHC, I'm not aware of DHCS allowing us to bill the T1014. You would bill your T1015 for your PPS or your air rate.
and then you would not bill the Q3014 with that then too, right? Because the T1015 would cover the whole thing.
Right.
Okay. Thank you.
Can you clarify the place of service POS 02? It has been stated for FQs to not add the POS 02, and then it was stated to add the POS 02.
So for FQHCs and RHCs, you would not use the place of service code 02 for Medi-Cal, and you would also not use the 95 modifier. So it is different. The billing instructions are different for fee-for-service providers and for RHCs and FQHCs. And I will note that that is specific to Medi-Cal claims. Now, your managed care claims can actually be telling you otherwise, and you would have to follow the plan's billing instructions. In particular, you would not use the place of service code 02 or the 95 modifier.
Do the G0071 telephonic calls have a time minimum requirement?
I think that question is for me. So for May, does it say if it's for Medi-Cal or Medicare?
It does not.
It is not? Okay.
Yeah.
For Medi-Cal, when you're billing the G0071 for your audio only telephone visits that do not meet the documentation requirements, I'm not aware of a time limit, but if you're referring to billing for the G0071 for your virtual visits, it would have a time limit, as Carol mentioned earlier.
Yeah, it looks like 5 minutes.
Yeah, so there are quite a few questions left here. I think some of them had been answered earlier, and some have been answered by the frequently asked questions that Carol and Bao went over, but we will download all of these. Again, we'll leave this open for like another minute, so if you did accidentally put a question into the chat, please bring it over here to the Q&A so we can download it afterwards. But I wanted to thank Carol and Bao again so much for your expertise in doing this webinar today. Thank you again to our sponsors, the California Healthcare Foundation and National Consortium of Telehealth Resource Centers, for sponsoring this webinar. And thank you to all the members of the coalition for their continued support and work for telehealth policy in California. And last but not least, thank you to all the audience members for your great questions and attending today's webinar. We hope it's been helpful, and we hope everybody stay safe and have a great day. Thank you.